Hi, everyone, and welcome. Today, we're diving into male fertility diagnosis, a critical topic that affects millions of couples worldwide. If you're watching this, you or someone you care about may be navigating fertility challenges. Here's what you need to know. Male factors contribute to about 40 to 50% of infertility cases, either alone or combined with female factors. But here's the important part. Diagnosing male infertility isn't just about reproduction. It's also a window into overall men's health, with connections to metabolic diseases and other conditions. Let's break down how doctors evaluate male fertility, step by step. The clinical evaluation. The diagnostic journey begins with two fundamental steps: a detailed medical history and a physical examination. During the history, your doctor will ask about several key areas. How long have you been trying to conceive? Any previous pregnancies? They'll explore your sexual health, erectile function, ejaculation, and libido. Your medical background matters too. Childhood issues like undescended testicles, previous surgeries, infections like mumps, or any testicular trauma. Lifestyle factors play a huge role. Smoking, alcohol use, obesity, occupational exposures to heat or toxins, medications, especially anabolic steroids, and any chemotherapy or radiation history are all relevant. The physical exam is equally important. Your doctor will assess secondary sexual characteristics, measure testicular size using an orchidometer, check for varicoceles, those enlarged veins in the scrotum, and examine the vas deferens and epididymis. This structured exam can point toward specific causes. For example, small, firm testicles might suggest primary testicular failure, while absent vas deferens could indicate a genetic condition requiring CFTR gene testing. Semen analysis, the cornerstone. Now, the most critical diagnostic tool, semen analysis. This test provides objective data on sperm concentration, motility, morphology, and other parameters. Proper preparation is essential. You'll need to abstain from ejaculation for 2 to 7 days before collection. Consistency matters if you're doing repeat tests. Avoid fevers for the preceding 3 months, as illness can temporarily worsen results. The sample is collected through masturbation into a sterile container, ideally at the clinic. If collected at home, keep it at body temperature and deliver it within 1 hour. Here's crucial information. You need at least 2 samples collected 1 to 4 weeks apart to account for natural variability. What are doctors looking for? Normal ejaculate volume is at least 1.5 milliliters. Low volume might suggest obstruction or retrograde ejaculation. The pH should be 7.2 or higher. Acidic pH can indicate absent seminal vesicle contribution. For microscopic parameters, sperm concentration should typically be around 15 million per milliliter or higher. Progressive motility, sperm swimming forward, should be at least 32%. Morphology uses strict criteria, with around 4% normal forms being the reference. The lab will also check vitality to distinguish live immotile sperm from dead ones and look for white blood cells that might indicate infection. Common patterns include azoospermia, meaning no sperm in the ejaculate, oligozoospermia, reduced concentration, asthenozoospermia, reduced motility, and teratozoospermia, abnormal morphology. Each pattern guides further testing. One critical point: a single abnormal result isn't diagnostic. Repeat testing is essential before drawing conclusions. Hormonal evaluation. Hormone testing helps pinpoint whether the problem originates in the testicles or with hormonal signals from the brain. The key hormones include FSH and LH, which stimulate sperm production, and testosterone. Total testosterone should be measured in the morning between 7 and 10 a.m. due to natural daily fluctuations. Prolactin is checked because elevated levels can suppress fertility. TSH evaluates thyroid function, which also influences reproduction. How do we interpret these? Elevated FSH with small, firm testicles typically indicates primary testicular failure. The testicles themselves aren't working properly. Low testosterone combined with low or normal gonadotropins suggests secondary hypogonadism. The brain isn't sending proper signals to the testicles. This requires evaluation of pituitary function and possibly referral to an endocrinologist. Imaging and advanced tests. Scrotal ultrasound isn't routine for everyone, but it's valuable when the physical exam is abnormal, when there's pain, or when testicular size is concerning. Using a high-frequency probe, doctors measure testicular volume, assess texture, and look for masses or varicoceles. While ultrasound can detect subclinical varicoceles, the clinical exam findings are usually more important for surgical decisions. Transrectal ultrasound comes into play when there's low ejaculate volume, with signs suggesting ejaculatory duct obstruction, like acidic pH or low fructose levels. This imaging can reveal dilated seminal vesicles or cysts that might be blocking the ducts. Now, when does genetic testing become necessary? When sperm concentration is severely low, below 5 to 10 million per milliliter, or with azoospermia. When the vas deferens is congenitally absent, CFTR gene testing for cystic fibrosis is essential. A karyotype checks for chromosomal abnormalities like Klinefelter syndrome. Y chromosome microdeletion testing looks for deletions associated with sperm production failure. Genetic counseling before testing is crucial because results have implications for offspring, especially with techniques like ICSI that can transmit genetic conditions to male children. Advanced sperm function tests include sperm DNA fragmentation analysis, which is helpful in cases of recurrent pregnancy loss or failed IVF attempts, and anti-sperm antibody testing when severe agglutination is present. Putting it all together. Let's walk through a typical diagnostic pathway. After the history and physical exam, you get at least 2 semen analyses. If results are normal, evaluation shifts toward female factors or comprehensive couple assessment. If abnormal results persist, you'll get hormonal testing, FSH and testosterone, and examination for varicocele. Scrotal ultrasound is added only if the exam is abnormal or there's pain. For azoospermia specifically, the critical distinction is obstructive versus non-obstructive. This determination uses testicular size, FSH levels, transrectal ultrasound, and genetic testing. Obstructive azoospermia might be surgically correctable, while non-obstructive cases may require advanced sperm retrieval techniques for assisted reproduction. When should you see a specialist? Red flags include abnormal hormones suggesting pituitary disease, azoospermia or severe oligozoospermia, any testicular mass, genetic abnormalities, or when assisted reproductive technology consultation is needed. Male fertility diagnosis is systematic and evidence-based, starting with simple tests and advancing based on findings. The good news is that many conditions are treatable or manageable with modern reproductive techniques. Remember these key takeaways. Proper semen analysis requires correct preparation and at least 2 samples. Hormonal testing distinguishes where the problem originates. Imaging and genetic tests are targeted based on initial results, not routine for everyone. And importantly, male infertility evaluation isn't just about reproduction, it's about overall health. If you're going through this process, know that you're not alone. Work closely with your healthcare team, ask questions, and remember that advances in reproductive medicine offer hope for many couples. Thanks for watching. If you found this helpful, please like and subscribe for more evidence-based health information. Visit our website for free consultation, www.bookehealth.com. Take care and best wishes on your journey.